So no apologies, Chair, other than the two that you've mentioned, and Joe is representing Neil.
Sure, that's great. I'll record those at the appropriate time. I make it that we're at 1 o'clock, so if everybody's sitting comfortably, we'll begin. Welcome to the public meeting of the Worcestershire Acute Hospitals Trust Board. I'm Simon Murphy, Deputy Chair, deputising for Chair Russell Hardy, who's currently on annual leave today. Before we start, just a couple of things to say. Firstly, we've just had a very successful board workshop this morning, where we received an update on a patient story from our chief nurse and our chief medical officer, our joint chief medical officer, which shows that there's still a lot we need to do as a trust to ensure that our patients and their families get the support and the services that they require from us. We're acting upon the learning from that particular very sad case. We welcome David Mahaffey, who's the Executive Director for Health Inequalities, Integration, and if I get his title correctly here, I think there's something else in there, Strategy as well, at the Integrated Care Board, who gave us a presentation on bed modelling across our Herefordshire and Worcestershire system, particularly as it pertains to us at the acute hospital here, and that was very helpful, and I think reinforced some of the things we're trying to do here as a trust to ensure that patients get treated in the right place at the right time. And then we had presentations and discussions from our Chief Operating Officer, Helen Lancaster, and Joint Chief Medical Officer, Julian Bellette, about some of the work we're doing on frailty and length of stay within the trust. So we've had a busy morning. I think we're well set up for our board meeting now, but before we formally start, I'd just like to point out and say thank you to Richard Oostrom, whose last meeting this is. Richard's been with us now for, I think, 7 years. He's seen a lot of changes take place at the Acute Hospitals Trust in Worcestershire over that time, and has been party to some of the important decisions we've taken to get us to the point where we are now, which is in a much better place than when he first joined. So on behalf of the board, and a number of us have done this individually, I'd like to thank him for everything he's done for us and for the people of Worcestershire, and wish him every success in whichever other ventures he continues to go forward to. So thank you, Richard. You'll be missed, but all good things come to an end, I'm afraid. Right. Off to the business of the day. Firstly, apologies. Russell Hardy, Chair, Glenn Burley, Chief Executive, who's also on annual leave, and Joe Kerwin is standing in for Neil Cook, our Chief Finance Officer, who has been off on sick leave for a little while. Do we have? I don't think we have any other apologies from anybody else around the gallery. Don't see any hands going up. No, in which case we'll record those. Declarations of interest. Are there any declarations of interest that anybody wishes to make above and beyond those that we've already got recorded? No, I don't see any hands going up. I put my hand up here and thank Erica Herman, our company secretary, for pointing out that I haven't actually recorded on my declaration of interest the subsidiary companies that I'm a director of by dint of being the independent chair of the Sandwell Estates Partnership and the Arden Estates Partnership, for which I'll be updating my declarations of interest. They don't come with any extra pay for being the independent chair of those two companies. They're just subsidiaries, but I'll make sure that the declaration in my name is as accurate as it needs to be. Moving on to the minutes of our last meeting, is everybody happy that they're a correct and accurate record? Tony?
Yeah, thanks, Chair. It's just a small matter of clarification, please, because I couldn't make the wording out. I'm on page 3 of the minutes and page 3 of the pack. In the final paragraph before the one that's headed quality, it's a sentence word referred to urgent care tasks and ask for clarity regarding a reference to one provisions or other provided provisions. And I couldn't quite make sense of what they're trying to say. I just wonder if it should be saying a reference to our provisions, but perhaps somebody could help me out there. It makes sense as it reads at the moment.
Can anybody clarify that for us, please? Don't all rush at once. Did everybody get it? Because you were a bit muffled as you were speaking, Tony. It might have been your microphone.
Apologies. Yeah, it's on page 3 of the minutes. It's in the paragraph above the headline quality, and it's the first sentence where it concludes regarding a reference to one provision, which I can't quite make sense of.
Again, I'm looking to the gallery to see what anybody might say.
Chair, if it's in relation to the word one, I think I'll refer back to the previous discussion and provide an update, and hoping that that's acceptable to you, Tony, and then we can approve those minutes.
Is that okay, Tony?
Has a thumbs up. Because it's got a mic issue.
Okay, we'll take the thumbs up. That's great. So moving on to the actions from that meeting, who would like to take us through the actions that we've got going? I see 2 of them are closed, so I'm assuming the BAF and the car parking at this stage are closed for the moment. Sarah, the IPC national guidelines, is that one for you to pick up? Sorry, Stephen.
No, if I let Sarah go, and then can I just come back to the car parking reception?
Please do, yeah. Sarah.
So around the IPC national guidance and adherence to that, we have regular conversations with the Health and Care Trust. It is an ongoing debate, I would say, around possible risk averseness, around accepting of patients not requiring side rooms. So it is an ongoing issue, Simon, that is being progressed. So for me, that needs closing.
Do we know when we might get some resolution? And again, just a bit of special personal pleading. I did have an elderly relative who was held up in our hospital for an extra 3 days as a result of the difference in the IPC procedures.
So as we know, every organisation has a executive DIPSI who is their accountable member on the board. We can influence, we can persuade, we can have conversations, but what we can't do is enforce practices on another organisation, and unfortunately that's where we are. So as I say, it is individual case by case conversations that are taking place at DIPSI level as necessary.
Okay, thank you for that, Sarah. Stephen.
Yeah, just to provide an update on the car parking and reception. So in terms of car parking, we're working really closely with other public sector partners that I'll hopefully be able to say more about in the next at the next board or one after. So that is progressing. There's a particular scheme that we're discussing that looks really positive. The other bit I want to say on car parking, particularly if it's colleagues who are working, we're doing a lot in the background. So I'm aware that we've had a number of situations where parking tickets or parking fines have been issued to colleagues who've not been able to park in appropriate spaces or whatever. So I've worked really closely with Scott around our approach to that and making sure that we address that. So if board members get feedback on that, direct them our way, we are resolving that. The other thing for Worcester Reception is, again, Scott has done a really good piece of work looking at what we can do with volunteers and what we can also do with minimal staffing given our cost pressures. And he has got a proposal that has been circulated around the execs, which at the start of it will at least provide Monday to Friday cover for the main reception in Worcester Royal, which is causing a particular issue, I know, for the volunteers and others around there, as well as members of the public coming in. So I just wanted to give that update, that we're, just because it's written like that, it's not that we haven't forgotten it, and I think we're getting close to resolution on those issues.
Thank you for that update, Stephen, both of which will be very welcome, I'm sure. I think batting it back to you now to your, oh, sorry, we haven't gone through the minutes of the foundation group held on the 2nd of May. Does anybody have any matters of accuracy for those minutes for those who are attending? And anything on the notes and actions that came out of that meeting? No, I don't see any hands going up. So Stephen, over to you, I think, for your Chief Executive's report.
Yeah, this is where I do my impersonation of Glenn. So I'm just going to pause there.
I'm sure we won't notice any difference. We won't notice the joins at all.
So I'll just pull out a couple of bits from the Chief Exec report. The first is around the improvement week, which we did with the foundation group, which I think Glenn's mentioned, but I was really pleased. One, in terms of our contribution, and a memorable shout to Jules for her session that she did. There was some really good feedback on that, and also the sessions that we joined in from the other members of the foundation group. And people and members of the public may be aware, one of the reasons for the group is that sharing of best practice and learning, and they don't always have to be the big things. That can be sometimes smaller things that you can spread at pace. And the other thing for board to be aware of is we've been using the Virginia Mason methodology, which some members of the executive and senior team went up to Leeds. So I just want to put on public record thanks to Leeds Teaching Hospitals for their accommodating of us, and it was a really good visit by all accounts, and we're going to do a particular exec session on it. And then I think, Karen, we've agreed previously I'll go through people and culture as well, a bit of a kind of deep dive on what the learning was from that. So that was really successful. So I just wanted to draw attention to that. I think the other thing that's important that I just want to pull out is around the financial escalation meetings that we've been having. There's obviously been a lot in the media around the financial challenges that are ongoing in the NHS. We have landed, or we are about to land, around a revised deficit of about 60 million, and we've been working really hard with ICS colleagues around that. Our cost productivity improvement plan is set around 45 million, and that's 6.6% of turnover. And I think it's worth, again, putting on record that would be the highest level of cost and productivity improvement that we've ever looked to set out and deliver. So there's a real challenge, but again, what's pleasing is the way that directorate and divisional colleagues are engaging with us around that, but that's not to underestimate the risk and challenge. A key part of that is around productivity. And again, there's been a lot of discussion at national level and using tools such as Model Hospital about the productivity gap that we face as a trust. And I think it's in the last paragraph, and I think it's quite stark, that says that the local data around us and our system is a workforce growth of around 10%, but we're 1.4% down on activity, which using their methodology shows a 10.4 overall productivity fall. Again, using the group and the work that we're doing around our cost improvement programs and productivity is around how we use that, how we deep dive that, and how we exploit opportunities, learning from others. And we are working with foundation group colleagues, and particularly David Moon and David Mowbray, that others may know, in a piece of work that we are doing within the trust. So just wanted to pull that through. And then I think there's two bits of really positive positive news. So the first, I want to give a really massive kind of acknowledgement and shout around 2 day case knee replacements that we've done in the trust. Colleagues will be aware this has been a long-standing issue that we've not been able to do this, and we actually on the same day had one happen at Kidderminster and one happen at Redditch. And I think particularly for members of the public, what's really important with these things is we often talk about our elective hubs and what that means, but this is really where Kidderminster and the Alex start to come into their own as really kind of helping us get through those waiting lists and do that in different ways. And I'm really pleased with the clinical teams, the way they've done that. And finally, the praise for the critical care team at Worcester Royal, where we had our CQC and they got an overall rating of good, which again, I think really kind of complements that journey that we're on as a trust, and more services turning good, which is a really positive journey for the trust. That's really all I wanted to pull out, Simon. There's a number of visits that Glenn's done and he references in, and again, thanks to colleagues for that. They're the main bits I wanted to pull out.
Thanks very much, Stephen. Does anybody have any questions or comments on the Chief Executive's report? No, I see no hands going up. Thank you very much for that, Stephen, if the hat fitted well. So moving on to the integrated performance report, I think you're going to kick us off on that as well, are you?
Yeah, and I won't be too long on this one. I think you can see the summary that's there. I think you can still see the demand that we've got within our elective and our cancer services, which remains high, which again links through to the report I've just referenced on why we need to get that productivity, because as much as I prefaced it with numbers, it's patience at the end of it, and that's the business that we're in, and that's the most important thing of getting through those waiting lists and people getting treatment. Again, I think the overall pattern will be one of some. We know the difficult areas we've got to tackle, but there are green shoots in there, particularly around our cancer performance. And another one that we are keeping a very close eye on around urgent and emergency care activity is that continued growth when you compare it to 2023. So working really closely with system colleagues to understand what that is, what we can do to improve it. And again, that's a system response, but we've got a big part to play in that. So on that, if you're happy, I will just hand over to, I think Helen will take us through the performance bit first, if that's okay.
Yep, over to you, Helen.
Okay, thank you, and thank you for that nice segue into our performance report. I'll take the report as read, but I just wanted to highlight a few key elements, and I think it is fair to say that we are beginning to see some green shoots across many of our metrics for different reasons. And so, as Stephen mentioned, our cancer performance is steadily improving, and we are expecting to see further improvement during May and June. Clearly, we're not exactly where we need to be, but we have really turned the corner since December. And I think previous months had highlighted the thanks that we'd had from the national team in terms of our significant improvement on cancer, and our improvement actually shifted the national position. And so we are still holding on to that. It's fair to say that we are still challenged across a number of tumour sites within cancer, but this month we have again started to turn the corner on those. So we're seeing improvements across all tumour sites now, even though we know that urology and skin have been particular challenges for us, but they are like they are improving. I think the next thing I wanted to just touch on is that we have seen a deterioration in our DMO1 in terms of our diagnostics, but part of the reason for that is that we have particularly focused on supporting the cancer recovery, and so have been putting extra additional sessions on to support the cancer pathways. We're now not starting to see our urology intervention unit come online. Staff have got their training completed, and we're still going through that recruitment phase, which will release some of that MRI capacity back. into diagnostics for more routine diagnostics. So still quite challenged across a number of modalities within diagnostics, but we are again starting to see we will next month you'll start to see those improvements in that recovery. From an elective point of view, again, looking quite positive, not exactly where we need to be, but improvements on our 78-week position. We declared 13 for April, but that number for May looks like that was probably just single figures, still validating some of that performance. And so next month we will have a clearer picture on that one. But pleased to say we have no 104-week waits. And then finally, from a UEC point of view, still exceptionally challenged around our EAS target, but we are starting to see this month particularly improvements over at the ALEX. But we have seen a significant reduction in our ambulance handover waits in terms of those protracted ambulance handover delays, but also we've seen a reduction in the hours lost from an ambulance point of view. So that's really, really positive. And we're starting to see a reduction in our 12-hour waits in ED. And I think our big challenge within the organisation actually relates to our flow, and so how we do the front door piece around trying to redirect and stream patients away from ED when they don't need to be there. We talked this morning about 82% of our walk-ins actually are discharged from ED, and 51% of our ambulances, patients turn up on ambulances, are actually discharged. So there is more for us to do in terms of that redirection, so that those ED is used for those patients that truly need the skills and competencies from a specialist ED team. And I think our EAS figure and our performance will probably be one of the last bits to recover, because we do need to move away from those long waits in ED waiting for beds. And so that discharge focus piece that we are doing across the whole system and redesigning that piece is really, really going to be absolutely key for us to supporting our UEC performance. So just take any questions. Thank you, Simon.
Thank you, Helen. Colin.
Thank you, Chair. You refer in your commentary, Helen, to clinical divisions are developing operational delivery plans to increase the volume of activity. Given all the other pressures on colleagues, are you satisfied with the progress that's being made across the piece?
Yes, Colin, and we also, I mean, Stephen touched on the day case needs piece, which is really around that productivity piece and reducing our reliance on inpatient beds. And we've also got some support in terms of driving that productivity piece from the group, and so we've started that. Some of those plans are around maximising our opportunities at Kidderminster and really looking differently now. I think it's next week the official designation, I think, of the elective hub for Kidderminster happens, and so we've got some real opportunities now to really drive those different pathways through Kidderminster and look differently about our day case activity.
Thank you for that, Helen. It's good news to hear that Kidderminster is quite close to that elective hub accreditation now. I know they've worked very hard on that, and I think that's onto the ALEX next, isn't it, to have a look at them. So if there are no more questions on operational matters for Helen, we'll move on to Sarah, I think, on quality.
Simon, again, taking the report as read, but the board will note that complaint compliance continues to struggle, in that in April our compliance for 25-day response was at 47.7%. Surgery division are continuing to struggle with their backlog of overdue complaints, and the focus support does continue from a corporate point of view. We continue to do well around falls and our hospital acquired pressure ulcers. We have had a challenge few months around the friends and family response rates, and there is targeted work with the patient experience lead nurse and quality matron working with the divisions to improve performance in this area. And Justine will update, I'm sure, in her report around the new maternity patient experience lead who is now in post. Around antimicrobial stewardship, overall compliance did drop in April to 88.9%. And we did fail to achieve the target, but we're really pleased to advise the board that our AMS lead pharmacist started on the 1st of April. So we are expecting improvement across all areas in this. So that's it from me, and I'll hand over to Jules.
Just see if there's any. Oh, sorry, Jules, of course, and then I'll bring Karen in afterwards. That's okay, Karen.
Thank you, Chair. Thank you, Sarah. Again, report as read, colleagues, just things to flag, obviously ongoing work with our fractured neck femur pathway, which I think board are cited on, and work on that continues. I'm hoping we should have some metrics showing some improvement to report over the next month or so. Sepsis remains a focus for us as well, with the switch from our paper to digital data collection, so that work is ongoing, as you'll see detailed in the report. And other than that, I'm happy, I think, just to take questions, Chair, because I don't think there was anything else particularly to highlight.
Thanks very much, Jules. Karen, I think you've got a question.
Thank you. It was for Sarah, who won't be surprised to hear me asking about the complaints. So I know it's a struggle, and we've seen, you know, a little bit of a helter-skelter with it and the roller coaster with the progress. But I remain concerned, as you know, clearly you do as well, about the position in surgery. And I know you've said we've talked about additional support going in. But given the position that doesn't seem to be having the desired sustained impact, my question is two things really. What are the next steps to trying to get some sustainability around the improvements? And the second part of the question is, are we losing the learning? Because if we have complaints that are just not coming through and we're not dealing with them, one of the biggest issues and gifts, if you can call it that way, that from a complaint is the learning from it. And if we're not dealing with the complaints, we're not getting the learning. So two parts really.
Yeah, Karen. So yeah, we do share your concerns as an executive team. We share those concerns around surgery and the sustainability around governance and to sustain the improvement that was made. What we've got though is a different set of issues, I'd say, around it is at the moment sheer volume going into that division, and what we've now got improvements in is around our clinician engagement, around our consultants being involved and investigating and responding to complaints, because we weren't in that place 6 months ago. So that is really very positive, and that's then obviously where we get the learning going into the division. The division has done a whole load of work in reviewing its governance structures and its way of overseeing the governance in the division and sharing the learning. So again, myself and Jules are more assured in that space. It's now about the new governance team actually embedding and making sure that those processes that have now been in place are actually working. So we are in a better place than we were, and the additional resource that went in is now finished, and it is just about making sure that the directorate managers and the support staff are actually continuing with that work. So it's work in progress.
Thank you.
Thank you, Sarah. Thank you for that question, Karen. Does anybody else have any questions on quality? No, in which case, Ali, we'll come to you for workforce, please.
Thank you. And as my fellow colleagues have done, I'll take the report as read and just pull out a few exceptions to note. Firstly, I must apologise. At the bottom of page 53 of the pack, On the left-hand side, there is a line around agency as a percentage of gross cost, which is inaccurate. It reads in the pack as an increase to 9.63, which actually reflects a previous month's increase. The actual figure is a reduction to 8.61, which you'll see in the detail and also in the summary at the beginning of the workforce section. And in relation to agency spend as a percentage of gross costs, as the board will know, our target is to get underneath 6% as a percentage. We are now at 8.61. We know that we have a particular challenge around medical agency use, and we are working really closely now with our divisions to support them with their plans to either eliminate or reduce that medical agency use, or where it's unavoidable, to make sure that we've got a clear plan as to how we come out of that agency use in a safe way, with appropriate recruitment or looking at skill mix and other things that we can do to try and reduce that reliance. We're yet to see that really reflect in the figures, and I think that will be some time until that comes out, because as you can imagine, some of the medical locum use is longer term locum use as well. So we need to make sure that we exit some of those arrangements responsibly to mitigate any impact that might have on services too. In addition to some of the close work we're doing with our divisions around agency usage, we are also trying to support with an improvement to sickness management as well. And we know that a number of our colleagues are struggling with stress and anxiety and mental health challenges. I should add that that's not all work related. That is a combination of reasons for that absence, and we are seeing that play out across our workforce and being one of the main reasons for sickness absence, unfortunately. We do have a plethora of support that's available for colleagues, and one of our focused efforts at the moment with our divisional colleagues is to make sure that we are fully exploiting all of the steps within our sickness policy to wrap that support around colleagues as well. So when people are absent from work, they have clear arrangements for keeping in touch. We've made sure that we plug people into the support that's available to them, and when they return to work, that they do so in a safe way that helps them to ease back into work, particularly if they've had a longer period of time off sick as well. So we are keeping a close eye with our divisions on that, and really looking for ways to try and improve the support to people as we move through that too. In terms of other elements to highlight, I know we've talked about this previously in board, but we are still focusing on trying to improve compliance with our job planning compliance as well. We do see this month and in month slight drop in that. We know that some of the issues around here are also about capturing the activity, that it's not always reported accurately. So we are working with our divisions to try and make sure that as that activity takes place and we have signed off job plans, that we get them through the system so they can report effectively as well, and trying to support colleagues to make sure that those job planning discussions are scheduled in a timely manner as well, so we don't see the drop off that we have this month as a few people have tipped over into a non-compliant job plan situation. Within the report as well, you will see some detail around turnover and sickness, specifically related to healthcare support workers and our nursing midwifery colleagues. Healthcare support workers is an area that we are focused on and we are trying to improve on from a perspective of sickness. And also we know that despite us having globally very good turnover metrics, and we know that we retain our colleagues very well compared to other organisations, we know that healthcare support workers is a pinch point for us, and it is an area where we do see higher turnover than we would like. And plus, we know that sickness has been a concern there too. So that support is in there. There is some focus work around working with healthcare support workers as well in terms of career conversations and wellbeing support. So that's firmly on our radar and something that we're working hard with. Other than that, I will finish on a positive that we have consistently good compliance with our statutory mandatory training as well, and benchmark really favourably there, and we are making sure that continues as well. Happy to take any questions.
Thank you very much for that, Ali. Karen and then Richard.
Thank you. Yeah, congratulations on the mandatory training, because it has been sustained, and that those are really good figures. I just wanted to go back to consultant job planning. As you said, and we've seen the detail of the very comprehensive work programme and project that's in place around that. But it's just something that I know I've queried before, as well as others around the table, particularly Sue, or around the gallery, sorry. And I'm just trying to understand better the link between the job planning and appraisals, medical appraisals. I don't understand how we can have 90% medical appraisal, which is great, but then only 69% job planning, when they were always aligned in the past. So I just need some help in understanding that better, because I find that concerning.
Thank you, Karen. And I think some of that absolutely relates to that reporting piece that I mentioned as well. When we've scrutinised this with our divisions a bit further, some of it has been that some of that's not followed through the reporting system, that some of the job planning activities not been recorded appropriately. So I do think there's a gap there. That may not explain it all. I think there's further work for us to do there in terms of understanding that pattern and that analysis, but it certainly contributes to some of that.
Richard?
Yeah, I think, Ali, maybe some of it, but certainly doesn't explain the huge gap that exists. And job planning is really something, to get right. And so I'd be interested in understanding, when do you think, or what is the trajectory we've got in mind based on the plan that Karen mentioned earlier? The other question I've got is, and you need to forgive me here, but we've heard so many times that we're reducing bank and agency, and now you're saying the same. So what assurances can we take that it's going to happen this time? Because it's a really key element of our plan for this year.
Sure, thank you. I've noticed Jules has got a hand up, which I'm assuming is around the job planning. So I'll answer the bank and agency bit just whilst I've still got the microphone. From the bank and agency bit, there's no denying this is a really complex issue, and we've absolutely seen that improvement and sustained improvement in nursing midwifery line, but not the medical locum line. We do now, as you will know, we've reported into the Financial Recovery Board around some of our plans for that grip and control, and how we are organising ourselves differently with the divisions in terms of sharing some of that ownership and more of that line by line scrutiny around particular posts and involvement as well, so we can really challenge where there might be alternative arrangements, and also better exploit the relationship that we have with NHS professionals, who provide us with an awful lot of data around our use to help us understand our trends, but really challenge ourselves to make sure that we are using that properly. I think it's hard to give a definitive date as to when it will reduce, but we are working with our divisions to at least have that divisional plan when they are looking to exit out of particular arrangements. And we've seen some good examples where that's happened already within SCSD, where those plans have come to fruition. So I think we need to learn from that good practice and just help to bring the other divisions along in that space as well.
Thanks for that, Ali. Did you want to come back on that, Richard, or Stephen? Were you wanting to come in on that point as well?
Yeah, I mean, I think as well, if I can add a bit of context to it, so particularly the work that we've been doing with the improvement director. So I take the point, Richard, about, we may have said this in the past, but my experience is we'll have done things like, we'll have said, on one hand, we're going to reduce bank and agency, but then we're not signing off certain things or approving things in a certain way quick enough over here. And then the other bit I think we need to have is a normalised position. What's the normalised position? So if I think of last year when I came, we opened 2 extra wards, or we did extra things. So we've not normalised it. We haven't been able to paint that picture. But I think there's a fundamental way that the trust has been working, that it says we want to reduce high cost agency over here. So what we've done in the run rate meeting, which did drive an improvement in the run rate, is we then understood where we had high cost agency locums, and we weren't making fast decisions around that's a recruitment, or yes, you can do something different with that. So I feel like part of the movement and part of my assurance is that actually we're doing both in tandem. We're not just kind of on one hand going, we're going to reduce it, and another hand, we're going to stymie you by not making a decision over here. So I think it's a much more coordinated point of view, and I think that's driving the run rate that correlates with the lower agency numbers that I'm seeing. But there's a lot of work to do, and we've got to keep going really hard at that.
Thanks for that additional information, Stephen. Jules, was it on job planning you were coming in on?
I was going to, Chair, yes. I think there's several elements that I just want to touch on. So I think over the last few years, recognising challenges we've had with job plans or job planning for our consultants and senior doctors is we have probably dissociated a little bit between appraisals and job planning, which is why the appraisal data sits relatively well and comfortably still, and the job planning doesn't. So I think that is what's happened, and we need to link those two back together more robustly. I think that is the truth of that kind of line. I personally think the job planning and the bank and agency are also linked, and probably more closely than we realise. If we can sort the job planning out, then I believe the bank and agency will fall into place behind it, because we can't essentially reduce one without the other. In terms of a timescale, the job planning has been an issue for some time. And therefore it's not going to be a quick fix. It's going to take time. We've already started that process of working through essentially what our rules of engagement will be with our job plans, working through those with our colleagues. But that is going to take time. So I wouldn't want to give the board any false assurance that we're going to see anything dramatic happening particularly quickly, but we will see improvement. But I think it's just the recognition of that it is going to take a little bit of time. And the bank and agency, I think, will come with it. But we are continue to work on both separately, if that makes sense, in the interim.
Thanks very much, Jules. A question in the chat from Richard. Just you have how much time do you think?
I will report back on that next month, Chair, if that's okay, once we've had a little bit more work done and give us a bit more of an understanding of where we are and exactly what we need to do to fix it.
We'll send you the information, Richard. Sue.
Yeah, Jules has probably just about covered it, but I've just sort of noticed that Rosemary Smart contacted me earlier in the week, and I don't know if Jules had a chance to look at it. I suspect with what she said, very, very kind of her. There are issues with supported professional activities, either non-direct clinical care in people's job plans, and there's a lot of dispute over that, and she's had some feedback about. But I think Jules has covered that. But I thought I'd better just let her voice be heard.
Thanks very much for that, Sue, and for the minutes. Rosemary Smart from the Patient Public Forum. Does anybody else have any other questions or comments on the Integrated Performance Report? I see no hands being raised, in which case it's batting over to you, Justine, for the next couple of reports. So firstly, perinatal and then embrace, please. Stephen.
Sorry, just going to check. Did you want to go to Joe for the finance?
That mightn't be a bad idea, actually. I do beg your pardon, Joe. Skipping over the numbers.
I was in
please.
there as well. That's fine, Chair. Thank you. So
go
to
ahead.
follow suit with other colleagues, I'm taking the report as read. Start with month one's an unusual month in that we don't have any mandated reporting submissions to do, but nevertheless we recognise as an organisation that it's important that we maintain that oversight over our key costs such as pay, non-pay and also our elective income. You will see from the report that we've got some small favourable variances across pay and non-pay, so 100,000 on pay, 200,000 on non-pay. You'll also have noted from the report that we've applied a sort of like a purist approach to our variances, and I'll explain that a little bit more. So in month one, we haven't declared any CPIP, so the team haven't gone through and cashed it up as they normally would, and that just sits alongside timing with year end, planning submissions and also finalising our CPIP programmes. But as you can see from the charts that we've provided within the pack, where we've got negative variances across our CPIP. We can see where it's offset with the key lines where we're seeing delivery of schemes. So some of that across our reducing our cost base where we're covering vacancies, and also some of the items with regards to our reserves position. In month 2, the team are cashing up appropriately, so we will restate those variances for you in future months. What has also been positive to see is our performance across activity and income for our elective activity. And as the report highlights, that indicated it was just over £1 million higher than plan. I will edge on the side of caution in terms of the phasing of our plan. So April was a very low month. And it is something that we are looking at as part of our resubmission, but nevertheless another positive point for us. With regards to cash, within the report, we've highlighted our risks around cash support, noting the size of the deficit. A new finance framework was introduced last week, which basically means that cash support will make its way to the ICB to support the deficit of our system, which then will mean that we won't have to request cash support in the typical way that we have been. So that's positive. I must stress that obviously delivery of our position will be backed on cash out CPIP, so it's important that we start to see that reduction in the run rate for the position. And last but not least, capital. So again, report outlines the risks that we've got associated with it, and they remain moving into 24-25, as inconsistent with how we exited last year. And work streams continue to itemise and prioritise the various schemes against our limited capital allocation. And I'll close there, Chair, for questions.
Thank you, Jo, and apologies for overlooking you. Michelle and then Richard, please.
Thank you, Chair. Just a quick question. On page 63, there's a planned income of 9 million, but the actual income is 10 million. Do you know why the income was understated and you receive higher than you planned for?
Yeah, so some of this will be the phasing of the plan, and I think some of it is linked to the productivity as well. So when we submitted our first plan, and recognising that we've got about 9 million net of increased productivity that we're expecting to see, we phased that from months 4 to 12 in the original plan. So what this is telling us is that actually it appears that you're delivering increased levels of activity, so a continued trend from last year, and it resulted in month 1 at 1.2 million. So as I said earlier, we're re-looking at the phasing of the plan. But for me, this is telling us that we're already feeling the productivity gain across a number of areas within across the trust.
Thank you, Jo. Richard.
Yes, thanks, Jo. And some positive green shoots, and I'm really looking forward to month 2. See if it's sustained, obviously. But you talked about the new financial framework and how cash is handled. Part of that framework is also that we've got a reduction of capital, as I understand it. So, and I'm really quite concerned about that because we've already got a backlog in some of the equipment that we need to replace and the maintenance. So I think it's just appropriate to make that point here and to make sure that there's some risk analysis done on this that needs to come back.
That's a very good point, and thank you for raising that, Richard. So as part of the framework, and this is hot off the press, so it was only in recent days that we've received this update. So as part of the assessment that NHSE colleagues perform, is an assessment of the size of almost like the allowable deficit. So for us as a system, that would be 30 million. So what they're basically saying is you're 50 million shy of where we would expect you to be, allowable, I should say, not expect to be, allowable. As a result of that, there's a 10% reduction in our capital, and there's a significant chunk of that that will make its way to our organisation. Now, we're ahead of the curve in terms of communicating this to the organisation. So Vicky kindly chaired our capital prioritisation group last week. It was brought to the attention of colleagues that attended the meeting, and we're already starting that risk assessment so that we can understand the level of further risk that this provides to the organisation. I think the other important piece is to note that actually we're also looking at getting ourselves ready for, actually, should we receive notification that there is an increase in the allocation, we've got schemes that are quick to go to respond to that, so that we don't miss out.
Thanks very much, Jo. Sounds like we're mitigating that and getting ready for any challenges that might produce. One more time, any further questions or queries on the IPR? No, in which case we will move over to Justine for the next two reports, please, Justine.
Thank you, Chair. So this is the perinatal safety report for April. Again, I'll take the paper as read, but there's some challenges and some successes that I just want to highlight. Challenge-wise, we haven't met our KPI for booking by 12 weeks again. Unfortunately, we are a little bit delayed in what we used to refer to as SPA introduction, but we're now going to call it maternity self-review, so self-referral, sorry, so that we're not confusing with other work streams, improvement work streams across the trust. We really do need to embed this, because that will resolve women arriving in the service late. Our perinatal mortality rate continues to be below the national average, and we're really happy to report that we had no stillbirth or neonatal deaths in April. Our workforce KPIs are moving in the right direction. We are just reflecting some of the comments that Ali made around our support staff. We're no different within the maternity directorates and neonatal directorates either. And there has been some spikes in sickness in our neonatal unit that are being managed very closely. Our training is on trajectory to meet the 90% compliance that we need to be at by December. But one of our ongoing challenges, and I've talked about this here before, is the completion of our PDRs timely. We do continue to report some data issues in terms of accuracy, and our teams are constantly cleansing data to make sure it's as accurate as possible. And we have asked for some support with that going forward. Staffing, I'll just point out the issues around middle grade and junior challenges, but you can note in the paper that there are mitigations in place. And again, pleased to report that our consultant presence for significant events was again at 100%, so that's a really good achievement. Just reflecting back to Sarah's comments around FFT, we get a really good recommendation rate from our families, but what we don't get is a really good response rate. This has deteriorated over time, and we now have an additional patient experience midwife in post for 12 months to support the work that our existing midwife has been doing, and her focus will really be about trying to get our response rate in a better place here. She's got some really good ideas and has already started putting some things in place, so hoping to be able to report an improvement next month. Delays in induction, you'll see a significant decrease, which is really welcome, and we're getting into a better place. And from a CNST perspective, you will see our quarterly reports there. Within the report, there's just one area of concern that's flagging at the moment, which you'll see in the PMRT element 1. That's amber at the moment because of a late notification of a baby, and that's something that I'll need to talk to NHSR about as we progress through the scheme. At our Safety Champions meeting on Friday, we discussed an emerging risk. We've got some reduced image quality on some of our scan machines in our antenatal clinic. There are some mitigations in place. When measurements can't be taken, alternative screening arrangements are made. That is the normal pathway. and we will continue to monitor that deterioration of image quality and replace those machines timely to an appropriate machine as we move forward. And I'll pause there and take any questions.
Thank you, Justine. Any questions or comments, please, on the perinatal report? See no hands going up. Thank you very much. Justine, moving on to Embrace.
Okay, so this is the Embrace report, reported on data from 2022. This is a kind of summary report. We don't normally get a report till the back end of this year, but this is a ahead of time report, which is very helpful for learning. And we'll get the full report later on this year. And if there are any changes, obviously we'll report those to board. So we reported 22 cases that were included within the report, sadly 17 stillbirths and 5 neonatal deaths. You'll see in terms of our performance, we are overall within 5% of our comparator trust, and that's a sustained position from where we were in 2021. You know that our 2023 data, crude data, looks to demonstrate a significant improvement, and we look forward to seeing that report at a similar time next year. Of the 17 stillbirths, you will see that only 5 of them were graded in a way as such that different care may have made a difference to the outcome. The majority of those were raised as SIs, and the others were reviewed through our PMRT process, which is reassuring that we're reporting and investigating correctly. As the same with the 5 neonatal deaths, only 1 was graded C or above, and that was also reported as a serious incident, and learning from that you'll see is in the appendices to the report. Some areas of good practice, you'll see 100% offer of post-mortem examination, and some areas for us to improve, to highlight notification of death in 7 days and the completeness of our data, particularly when our babies are born somewhere else and then come back to us, and having that liaison with those other services to make sure the submissions are complete. So I'll pause there and take any questions on that report.
Thank you, Justine. Again, any questions or comments? I see no hands being raised, so we'll move on to safe staffing, which I think is a bit of a duo, starting with you, Sarah, and then coming back to you, Justine, I think, if required.
Simon. Okay, so take the paper as read. Pleased to say that staffing on paediatrics, neonates and adults maintained safe levels throughout April. Our agency spend is continuing to reduce, and the swapping out of agency workers into substantive staff also continues to go well. Pleased to say that our RM vacancies as of March sat at 2.84%, so we are having an improving position month on month, along with our healthcare support worker vacancies, which currently sit at 5.90, again improving month on month. Our RN registered nurse total absence due to vacancy, sickness and maternity leave in March sat at 292. Of those 292, 90 of those nurses were on maternity leave. The only way that we can fill or keep our ward safe when staff are on maternity leave is to backfill with agency or bank staff. And we are just agreeing a paper where we look at funding the maternity leave within funded establishments, which obviously from a safety and continuity point of view would be better, and it would further reduce that agency spend. We had no serious issues in relation to staffing throughout March and April. There were 26 insignificant minor instances reported. And one thing to highlight within the report is the work that the team have been doing with supporting other hospitals with their international nurse recruitment, which has brought in a small additional income of £17,000. But we are now working with both ICS and regional colleagues around whether this is something that we could do as an income generation, but also to support other trusts across the NHS. So I will stop there and happy to take questions.
Thanks very much, Sarah. And I said hello to 3 nurses who come from Osler Street to benefit from our training recently. Karen.
Thank you. Well done, Sarah and team on the vacancy rates, because those are really good in terms of the progress made there. I also had a question about the mat leave cover, part of which you answered in terms of the work you're doing, and that makes absolute sense. I wondered as well, though, if you're also looking at over recruiting, because there's always going to be an element of maternity leave, and have people just substantive staff covering that. I didn't know if that was something that was being looked at all.
I mean, that is going to be a conversation that we are going to need to have, Karen, and I'm kind of waiting for us to get to that point where we are more or less fully established, fully recruited to. I suppose with our escalation areas remaining open, it's great news we've closed Akenbury 0, but I think until we need to look at staffing those areas if they are to remain, and then we will have that over recruitment conversation, but certainly it's one that's planned.
Thank you.
Thank you for that question, Karen. Justin, was there anything you wanted to add to the safe staffing report?
Yeah, so it's important I say, obviously, that within maternity, we've also met safe levels throughout the month. You'll see there from our KPIs that our sickness is down in both groups. Our turnover is down, although very slightly up for midwives, but actually that's somebody who retired and returned. So again, that sort of reflects some of the changes that we've had over the last 12 months. As I say, we didn't meet our supernumerary status of shift leader 100% of the time across the month. There were 2 occasions where they reported that they weren't able to be, but some of the real highlights are we met acuity at 76% of the time, which is one of the highest for some months, which means that we haven't been needing to go into escalation and move our staff around quite so much, which we all appreciate on the gallery is never popular. There were only 2 episodes when we were requesting support from our continuity and community midwives. So that's a real improvement from a health and wellbeing perspective. And also we were fortunate to be able to offer 16.5 whole-time equivalent posts for newly qualified midwives who will start with us in September and October. Which you'll see from the paper and the number of vacancies that we will have very few vacancies by the time we get to that time. So all good news, and both now our international midwives have both got their PIN numbers, so they are working as midwives in their blue dresses in our service and looking very happy. So, and we welcome them with open arms. Take any questions.
Thank you very much, Justine. Again, any questions or comments, please? No, in which case, thank you to Sarah and Justine for the safe staffing report. Very conscious of time, colleagues. We're now coming to some items for approval. We do need to move on as quickly as we can. So coming to you, I think first, Jo, for the ICS Joint Forward Plan.
Yeah, thank you, Chair. And we're asked to both ratify this, but also to delegate approval to Stephen as the MD, just in terms of the final financial bits that need to be included. I'll assume the paper has been read. I'll just step you very briefly through the main areas of it, just because it's a little bit complex. So this is a joint forward plan. It's actually a rolling plan for a 5-year period. If you like, it's the NHS contribution to the wider ICS strategy and the 2 health and wellbeing board strategies, which is outlined in the paper. We first saw it a year ago. There isn't a lot in terms of material changes in the plan. Those changes that there are outlined in the cover paper, and it has been updated to reflect joining the foundation group and a greater focus on the best use of resources and benefits realisation, etc. It's been to the ICB board last month where it has been approved. And I think given the board development discussion we had this morning, hopefully you can see how the thrust of it in terms of providing good health and wellbeing to the whole of the population in Worcestershire, but also being consistent with the discussion about left shift is very much reflected in there. And the focus over the next time period is to make sure we can deliver best value care. So there's lots of detail in it. There's 2 appendices and a main document, but happy to take questions, Chair, given where we are.
Thank you very much, Jo. Any questions or comments, please? Okay, no hands raised. So we are approving the document here, but also delegating the financial aspects to Glenn and Stephen. Is that correct? Okay. If you're not happy to approve, please raise a digital hand. Thank you. We take that as approved and delegated appropriately. Financial recovery plan, Jo.
Sam, I'm going to take this one if it's okay, and it's just a really brief update. We've had a number of discussions at board about the financial recovery plan. I went for a seek forgiveness, not permission. So we're doing a detailed piece of work with Jo just to recast it in terms of the financial plan and the settlement that we've had this year. So if you remember when we first started, we had a CPIP a cost improvement productivity target of around 30 million, and obviously we're significantly higher than that. So what we're doing is a quick piece of work to just recast it in terms of the 3 and the 7 year bit. So if board are okay, what I'd like to do is take it through a detailed board development session and then probably a summary of that, which could then go to the board for final sign off. The fundamentals of it don't change. It's just we want to just make sure the numbers are the more accurate, given that the kind of financial settlement that we've ended up with and the subsequent rounds of planning, if that's okay.
Thanks for that clarification, Stephen. Does anybody have any questions or comments on that? So we can expect it to come back to us in a different form at some stage, but basically the basics are the same. It's just the new numbers, as it were. In which case, if anybody disagrees with that course of action, please raise a digital hand. We'll take that as approved. Moving on to the quality account, the annual quality account, Sarah.
Yeah, so we are required to publish a quality account annually as set out in the Health Act 2009, and we do need to publish our quality account by the 28th of June by uploading to our website and then forwarding on to NHS England. As we can see, the draft quality account has been through Trust Management Board and the Quality Governance Committee, and then finally to here for approval. I can confirm that the content of the quality account does meet the legal requirements as set out in the Health Act 2009, and it's consistent with internal and external sources of information. We have received our external views from both the ICB, Healthwatch and our Patient and Public Forum. And there is just 2 points that I would like to add into this document that we have in front of us, which were picked up through our external reviews. The first is around, we didn't make any reference to car parking, and this is one of the key themes that comes from our patients feeding through to the Patient Public Forum. So I would just like to add a line in on that. And the second, which is from Healthwatch, is the work that has been undertaken around sepsis. And that was omitted from the quality account. So I do want to just add a small section in on that. I'm not going to go through the report in detail. I think it demonstrates the commitment of all of our divisions and team in improving the quality and the patient experience for our patients. And I really do thank the teams who have pulled the quality account together. So I'll stop there and happy to take any questions.
Thanks very much, Sarah. And I know it's had a good airing at the Quality Governance Committee. Does anybody have any questions or comments for Sarah, please? In which case, noting the additions on car parking and sepsis, if anybody's not happy to approve the report, please raise a digital hand. No hands up. Thank you very much, Sarah. Back to you, I think, for Infection Prevention and Control Annual Report.
Okay, thank you. So I think no surprise to the board that it's been a really challenging year for the Trust in relation to healthcare associated infections. And we have breached all of our 7 standards, which is detailed within the annual report. However, it should be noted that nationally and regional, we have seen an increase in the number of HCI cases And over the 10 months since I've been chairing the TIPSY committee, I have seen improved working relationships between our corporate teams from estates, facilities, procurement and IPC, which is where we need to be if we are to work on this collectively. So we are now seeing more assurance coming through TIPSY and through to the Quality Governance Committee. We do understand our challenges and our pressures, and some of those difficult conversations that do need to take place are now beginning to happen. So following the self-assessment against the criteria in the Hygiene Code, the Trust is able to declare compliance with the Hygiene Code for the year 23-24 and also declare partial compliance with the IPC Board Assurance Framework. The reason we are only declaring partial is because there are ongoing cleanliness concerns and there are ongoing conversations with our PFI provider. We do have gaps in estate maintenance priorities, particularly on the Worcester side. Our AMS antibiotic prescribing, we've already talked about that requires further work, and our ability to isolate our patients who are identified as having an infection timely because of issues with side rooms. So I will stop there. There is lots and lots in this report, and it has had really good airing and discussion through TIPSY and the Quality Governance Committee, but I'm happy to take any questions.
Thank you, Sarah. Again, any questions or comments on the annual IPC report? No, in which case, if you're not happy to approve it, please raise a digital hand now. Thank you. We take that as approved. And back to you again, Sarah, for the safeguarding annual report, please.
Thank you. Okay, so Safe annual report highlights the work undertaken in 23-24 to provide assurance that we are compliant with our statutory obligations in relation to children and adult safeguarding. And I have to say that this annual report really demonstrates the heavy lifting that the Integrated Safe Committee has done over the last 12 months. The work and their standing in the system is commendable, and I think the annual report does reflect that. Board will recall that we asked ourselves, could this happen here in relation to the Lucy Letby case? We have met our obligations in relation to prevent, and also our statutory obligations as a partner of the Worcestershire Safeguarding Children Partnership and the Safeguarding Adults Board. One thing that I do want to get under over the next few months is our Mental Health Act detentions, because they do continue to exceed the numbers that we should have within the Trust. So our contract with the Mental Health Trust is to have no more than 20 Mental Health Act detentions throughout the year. And as we can see that we're currently exceeding 70. So it's a poor patient experience with patients in the wrong environment, but it's also the pressure on our staff. And as you can see in the report, predominantly patients are sectioned and held in our acute medical units, which are very fast paced and full of medical patients who are acutely unwell. So I'm very happy to put forward to the board that we are meeting our full statutory responsibilities in relation to children and adult safeguarding. Happy to take any questions.
Thank you, Sarah. Again, any questions or comments for Sarah, please? Noting the challenges that we've acknowledged in the report, if anybody's not happy to support adopting the report, please raise the digital hand. Thank you. We take that report as adopted. Now moving on to items for noting, we look at our committees and if there's anything to be reported by the chairs of those committees to us. Firstly, Quality Governance Committee. It might be Sue this time, I think, though Julie may have something to say as well. Is there anything you want us to be aware of from that document?
Yes, there's a couple of good things. We're very pleased to hear there's quite a lot of widespread work, good work going on in relation to retention of staff in lots of areas. And we've got an learning difficulties steering group, which was very welcome news, and I think is going to make a huge difference to the quality of care of our patients, and I think puts us a bit ahead of the curve. There were a couple of things that we were going to raise to committee. There were, because bear in mind, this is the 24th of April meeting, questions about general engagement with the EPMA, but we've actually had a subsequent meeting because we're not quite synced maybe yet. And we heard about progress then. In fact, we had a meeting on the 4th of June with Vicky and her team, which sounded very positive in that we will improve our understanding of how we go about implementing the EPR. And we had an update on which has been previously raised before, on the label windows. I'm much more comfortable with the plan in place now. It's not a permanent fix yet, but it's going to improve with some secondary lining on the windows, and then with a plan to actually do a complete replacement with proper double glazing after the winter period, because obviously it wouldn't be appropriate to do it then, and it's got to be synced in with clinical activity and so forth. But both of those have moved on quite reassuringly since the 24th of April meeting. I don't know if you did want to add anything, Julie.
I was going to say, is there anything, Julie? I think you're still on mute, mate. Try now. Can see your lips moving. We can't hear your voice.
Your mic icon is not there anymore. Is it the headset?
It's okay.
International
We're
language
okay
smiles.
to proceed. Absolutely.
Thanks, Julie.
Moving rapidly on. Thank you, Sue.
If there's any questions about any of that.
Indeed. Any questions or comments? No. Colin, audit and assurance, please.
Thanks, Chair. We got 3 internal audit reports at the committee, and I just wanted to highlight to the board that in one case we had a limited assurance in the area of consultant job planning, and given the conversation we had earlier about progress in this area, this was a matter of disappointment and concern to the committee. We are going to receive an update, I believe, from Jules and/or Julian at our next meeting, and it's also had consideration at People and Culture, but I think it is a matter that we need to be aware of at board level. We also were told by the head of internal audit that at this point in time, it looks likely that we will have a limited assurance audit opinion for the annual opinion, which again is disappointing, although not necessarily a surprise. There are a couple of factors that have contributed to that. One is the fact that we have had some limited assurance reports, but the second factor that contributed to it was the fact that our responsiveness, both in terms of agreeing audit recommendations and then implementing whatever agreement has been made, is not as good as they would like it to be. They're obviously cognizant of the pressures colleagues are under. They make allowance for that, but I think it does actually pose a question for us as an organisation as to whether we need to think harder about the way in which the organisation responds to the work of internal audit. It is a key ingredient in the overall governance process. The only other thing I'd want to mention is the fact that we received a draft of the financial statements, and I am happy to say that the board has commended them forward, the committee rather has commended them forward for the board in draft form. They were completed in a very short time frame, so I think congratulations to Lynn and Joe rather, and the team getting it completed in the sort of pretty hot house environment in which these accounts have to be produced. And I think, Erica, we need to ask the board for delegated authority to finally sign off the accounts, which have to be submitted by a deadline at the end of this month. That's all I wanted to raise. Thank you.
You call in, Erica?
That is, given that they're both still in draft, we have that on the private agenda for today, before they are published publicly.
Thank you, Erica. Any questions or comments to Colin? No, in which case we'll move on to People and Culture. Karen, anything to bring to our attention, please?
Thank you. You've got the minutes of the meeting from the 2nd of April there, which I'll take as read. Happy to take any questions on that one, nothing to flag. Just to further add that we had the latest meeting on the 3rd of June, so the sequencing is a little bit awry, but just to let people know that at that meeting, which will be covered fully in the minutes at the next board meeting, so that we heard about the plans and proposals to begin the work at an early stage to improve the response rate to the staff survey, which was quite disappointing last year, but those plans are coming on strongly. We also received a programme of work around overpayments and heard from Ali and her team about the work that's in hand to review and reframe the risk register for the People Directorate, which was really helpful. Happy to take any questions.
Thank you, Karen. Any questions, any comments? Thank you very much. Moving on to the Board Assurance Framework and Extreme Risks. Erica or Sarah, I think got down for that. I don't know who's going to take that for us.
We can start, Erica.
Go ahead, Sarah, go ahead.
Okay. So as the board are aware, we had an out-of-date risk management strategy, and there were gaps in our processes around reporting and escalation of risk. The risk management strategy was approved by the board at the latter end of last year, and we have reviewed our risk management processes, which myself and Erica did together. So the reviewing of the BAF and the corporate risk registers remains ongoing progress. I think when you look at both the BAF and the high level 15 risks, you will see that there is more work to do. And we are doing that work through both the corporate risk management group that Erica chairs and through the executive risk management committee that I chair. But it's going to take us a few more months to get it to a place where we are comfortably happy with them. So I'll stop there, and it will be for individual execs to answer any questions around their risks associated with them.
Thank you, Sarah. Before I bring Karen in, Erica, is there anything you want to add?
Yeah, so the BAF is now hosted on Datex, which means that we can link risks to those high level BAF risks, and the BAF risks are those risks to us achieving our strategic objectives. Since the board last saw the BAF, the most significant change is the one around, it was described previously about digital resilience. We have revisited that particular BAF risk, and it's now more focused on cyber attack and the risk that would have to us achieving our strategic objectives. And then, given the news in the last few days with our London colleagues, that it seems appropriate that is at the level of risk that it is. So that is the one that has increased over time. We're continuing to provide rollout training across the trust to the new to the new risk strategy that Sarah refers to, and to make sure that what we're presenting to board is appropriate going forward, that we've actually nailed exactly what those extreme risks are and how they might link to the BAF.
Thank you, Erica. Stephen, were you coming on the general report, or was it a specific question, and I can bring Karen in first?
It's on the general. So I think one thing, and it's for members of the public who might be looking at it, but also I think for us, we've been doing a lot of work around the BAF, and we've been tying it into the value for money assessment as well that we get. So we're at a bit of a, I would describe a bit rock and a hard places, that we need the high level risk registers and things like this to be seen at board. But I think, as Sarah described, we're on a bit of a journey with that as well. So I wouldn't want anybody to get unduly worried by some of the language that's in the thing. I think we're on a bit of a journey with how risks are described. Some of that around it, because there's an awful lot of, some of the language in it is not, I think needs to be refined relatively quickly. But if we were waiting for it to be in a really good state, we wouldn't bring it to board, so we wouldn't be showing it. So we're kind of in that state. So I think there's just a note of caution that I would put to it around detailed work that we're doing behind the scenes, and particularly as it keeps coming to board about the language and how we use that. So we don't want to hide any risks, but equally we don't want to exercise anybody too much by just simple use of inflammatory language or language that may not be as tight as we need it to be around this.
Thanks for that clarification, Stephen. That's appreciated. Karen and then Tony, please.
Thank you. Totally hear what you've both said about work in progress, and understand your pain. Just to clarify that I'm reading this in the right way, I won't go into any detail on any of the areas given what you've said, but I just want to make sure I'm reading it the right way. So as an example, on page 395 of 431, which I think is actually the first risk, it happens to be the one around ligature points. Is what we're saying is that was first entered in 2019 and it remains an extreme risk. Bearing in mind you've got some tweaking to do.
Yes, Karen.
Okay, thank you.
And there's a whole load of work that I'm personally overseeing in order to manage this risk.
Okay, thank you. That's sufficient.
Thank you, Karen. Tony?
First of all, can I check you can hear me all right this time? Yeah, okay, there's a mic problem. Thank you. Yeah, mine's a general observation from experience in other organisations, because this is the proverbial elephant, and it's so big, it's difficult to get your head around it, and you could spend hours just going through this. I'm used in other settings for the BAF to be broken up by an owning committee. Sometimes that's not easy, and it's not easy to pigeonhole it into a committee remit, so some of it still has to sit with the board. But it gives an opportunity to have a more detailed conversation outside the board and then feed into the board any observations there. Now, there may be other governance arrangements that are equally good, but it's just a thought from experiences elsewhere. Thank you.
Thanks, Tony. I saw Erica's hand go up, so Erica.
The risk management system, DATEX, does allow us to identify a monitoring committee, and that's part of the progress of executive risk management. Is we're making sure that where a monitoring committee has been identified, that it is on their agenda and they are reviewing it. So it's that ongoing work to make sure we've got the governance of the whole risk management process right.
Thank you for that. Any further questions or comments on the board assurance framework and extreme risks? No. Stephen?
Sorry, just a couple of other observations. I think building on what Tony said, I think what we've got to expect is, as it gets more scrutiny, there will be a number of these risks, particularly the longer ones, that will probably we'll be having conversations around, are they actually a risk like that? Because I think one of the things you want to drive is a bit of consistency. So what I'm used to is you do kind of get this sometimes with services, is one scores something really high, the other one scores it differently, and you've kind of got to do a bit of mitigation between the two, so they're describing it. But I think we have to be honest with board as well. One of the things that I think, picking up on Colin's bit from audit committee, and a bit of a theme, is we've had some sticky issues in the trust that I think if we were being self-critical, we would say we haven't properly moved on at the pace we should have done. They will come through the risks. So there will still be, for a while, I think, some risks that look fairly long-standing. The commitment we've got is we need to get them resolved and sorted and moved on to a level. So I think it's a bit of a balancing act at the minute. One is really focus on those that have been there a long time, sticky issues, get them resolved, and the other is drive a consistency and do that in a safe way, so we're not just taking things off for the sake of it, but equally we're not leaving everything on and not really giving it the appropriate scrutiny. So I think it's just important context that we'll be going through in the next few months that Sarah's leading.
Thanks, Stephen. Clearly a work in progress. Sarah?
Yeah, just following on from Stephen, I think what we've had a couple of executive risk management committees now. I think we've had 3, and the first one was really an intro. Whereas now we're moving into reviewing each of the divisions each month, high risks of 15 and above, so that we can begin to get into some of that consistency and to really understand and support where necessary. But we've had to get to a place where we are before we could do that. And it's not, as Stephen said, it's not going to be a real quick turn around this. It is going to take a little bit of time, because the education and training is needed, as Erica referred to.
Thank you, everybody, for that, and obviously Sarah and Erica in particular for taking us through that. There's a major piece of work underway here, and we look forward to continuing to monitor it and react to it appropriately as it develops. On to any other business. Hasn't anything been notified to me? Is there any other business from the meeting itself? No. Questions from the public? Again, I don't think any have been notified. I don't know if Martin, I think you were here as Health Watch.
Yes, but I don't have any questions, Chair.
Okay, thank you for your attendance. It's always appreciated. If there are no questions from the public, date of next meeting is the 9th of July. Thank you all for your attendance, and I will see colleagues in. Happy to pull it forward to 2:45 for private board if everybody's happy with that. Just seeing a general nodding of heads, that brings us forward 15 minutes. So in which case I'll declare the meeting closed and see you all in 15 minutes.
Thank you.